And next up is Vitali Sintchenko, who will talk about whole genome sequencing. Thank you, Vitali.
Thank you, Jamie, for the introduction. Justin already made a point about personalization of therapy for tuberculosis that whole genome sequencing can allow, and recognition of drug resistance, whether it's MDR, which has been increasingly I don't have a pointer. Increasingly recognized due to implementation of different methodologies around the globe, largely about phenotypic susceptibility testing. And I want to make points that phenotypic DST, which is based on culture of Mycobacterium tuberculosis, has significant problems with harmonization and concordance between different methodologies. Okay. Okay, yeah, thank you. I can use the microphone and feel a bit more confident here. Yep. So there are no international standards for phenotypic DST based on culture, and several rapid testing assays endorsed by WHO provided capacity to diagnose MDR TB quickly using testing of clinical samples or cultures. And these tests include gene experts in different iterations and MDR-TB plus Hain assays, but only small number of drugs can be assessed by these assays due to number of targets in these PCR-based assays. And whole genome sequencing, which might seem like a luxury following the presentations yesterday and this morning, is amenable to standardization and gives you ultimate high-resolution genome-wide perspective on mutations conferring drug resistance. Warwick and Ben asked me to talk about this patient-tailored, individualized treatment, which is represented by multiple dimensions, really. And I'll be focusing really on the first dimension, which targets design of treatment regimens based on mycobacterial genotype, on genome sequencing. But you have to consider also host-directed therapies based on genetic variability of hosts, and if you like, genome sequencing of human host, and therapeutic drug monitoring that Ian Billam will be talking about in a minute, and biomarker-based treatment decisions. And CRE has been really targeting many of these aspects in our efforts. Cryptic Consortium is a fantastic example of international efforts to build catalogs of drug resistance mutations to enable this tailored therapy. We've been part of this international effort, and in a big publication in England Journal of Medicine several years ago, which is based on data generated between 2000 and 2016 in multiple centers. The conclusions that whole genome sequencing can characterize susceptibility to first-line drugs with a degree of accuracy sufficient for clinical use was achieved. More specifically, sensitivity of detection of drug resistance conferring mutations was higher than 90%, which is a WHO target, for essentially all first-line drugs except ethambutol, and specificity target of greater than 95% for molecular assays was also achieved for majority of drugs in different cohorts. In New South Wales, when you look at drug resistance profile, and this is a paper that we recently published, and Connie Lamb, one of our postdocs, led this publication, and data clearly makes a point about association between phylogenetic lineage, which can be inferred from whole genome sequencing, and frequency of drug resistance. You can see in total, MDR was 2.8% for a period of time, and this is almost 3 years between 2016 and 2019 data. Rifampicin resistance was much more commonly present in Beijing lineage, 6.6%, in contrast to a lot less common percentage in other lineages. And isoniazid resistance was present in 20% of Beijing isolates, for example, while it being detected in 11% of isolates in total. And this is another interesting and important trend that we see more and more isoniazid monoresistance, which is very relevant. So when you think about resistome inferred from whole genome sequencing data, since in New South Wales, sensitivity of whole genome sequencing for picking up resistance to rifampicin is 100%, and specificity is equally exceptionally high. For isoniazid is 93%, for pyrazinamide 85%. But when you look at positive and negative predictive value, especially negative predictive value, is very, very high. 100% for rifampicin, 99% isoniazid, almost 100% for pyrazinamide, and 100% for ethambutol, which means that really you can do this whole genome sequencing, and if there are no mutations, this is your answer. And you can do susceptibility testing only on a small subset of isolates to verify your predictions, really. So pyrazinamide is perhaps is a problem as far as positive predictive value is concerned. We can talk about this if we have time later on. So Connie looked at diversity of drug resistance conferring mutations according to individual lineages, and again you can see very large spectrum of mutations in individual lineages, and majority of them are in Beijing, as you can see. There are some differences in these mutations, but nevertheless the important point is that whole genome sequencing gives you this genome-wide view, and majority of mutations that confer increased MICs are reliably detected. And we also quantified the impact of whole genome sequencing in comparison to GeneXpert or Hain assay. You add almost 7% of additional resistance detected by whole genome sequencing, and 44%, because ethambutol markers are not included in this, from whole genome sequencing is gained, and pyrazinamide is a very significant gain for pyrazinamide resistance, is very significant gain for whole genome sequencing. I would like also to make a point that these gains differ for different lineages. Most significant gains are, as you can see, for European American and East African Indian lineages, as far as genome sequencing, and in comparison to GeneXpert and and Hain assays, and these differences are statistically significant. Recognition of heteroresistance is becoming more and more frequently discussed. We haven't seen mixed infections in this 1100 isolates that we examined, but we occasionally saw evidence of heteroresistance. So coexistence of drug resistance and resistant drug susceptible haplotypes of Mycobacterium tuberculosis is recognized as a problem. Macro heteroresistance and fixed resistance can be reliably inferred from whole genome sequencing data. Micro heteroresistance at subphenotypic levels potentially might be an issue, and you need really high throughput, high resolution sequencing with probably repeated sequence experiments. And this is just an example of accumulation of SNPs leading to a resistance to isoniazid and FABG mutation. Just one more example of this clonal diversification that has been recognized by whole genome sequencing of individual colonies from a solid media from a patient. So we're not doing this. We're sequencing midget extracts from essentially mixed growth of our organisms, but we suspect that will be some appetite, especially in complex cases, in similar work that has been illustrated in that paper. So this is repeated sequences of colonies over on fortnightly basis that shows subclones of Mycobacterium tuberculosis cultures and proportion of subclones which are resistant to different patterns of drugs, and this is just an example of high resolution genotyping of MDR-TB within host samples. All these examples summarize the important consideration for patient-tailored precision medicine approach in Mycobacterium tuberculosis management. They raise important questions about correlation between phenotypic testing and resistome, and the role of silent mutations or mutations with low confidence and clinical interpretation of such findings. But by and large, the predominant opinion is focusing on not which method is better. We think that whole genome sequencing resistome provides a lot more information in a harmonized fashion that can be compared across jurisdictions and across continents. But this battle for supremacy should be really managed by patient outcomes. So treatment outcomes, in essence, are the gold standard. And there is emerging data that even on a different mutation level, you can see the difference between rates of failures between patients. So particular mutations in gyrase gene, this is mutation type of mutations that are associated with increased MICs to fluoroquinolones, moxifloxacin, gefloxacin, levofloxacin, etc., can have differentiating impact on clinical failure. And there are some reports about increased mortality, difference between CAT-G mutation carrying strains and INH G-conferring strains. So reference mapping will identify these individual mutations. You can make a judgment whether high-level or low-level resistance can be inferred from these findings, and adjust your selection of therapy drugs, and phylogenetic variants can carry some information to help such decisions as well, to fine-tune timely pathogen-tailored therapy for clinical management of TB, especially multi-drug resistant and extensively drug-resistant tuberculosis. Thank you very much for your attention, and I would like to thank also our staff at New South Wales Health Pathology Mycobacterium Reference Laboratory and Public Health Genomics Laboratory, our collaborators internationally, and the University of Sydney, MBI, and the Ministry of Health, especially TB Control Program, led by Ellen Donnan, and our funders. Thank you very much.
For a question.
Thank you, Vitali. It's Greg Fox from Sydney. I just have a question about one of the points you made near the end around the gold standard of how we define the diagnostic accuracy of whole genome sequencing being measured in relation to patient clinical outcomes. And there's two challenges with that. One is there's such heterogeneity in other non-bacterial related factors that can confound that evaluation. And secondly, in a setting where we do lots of whole genome sequencing, like in Australia, we have such high treatment completion outcomes that it's actually you need enormous data sets to be able to have enough participants to see enough treatment failure and relapse to actually be able to distinguish that. So my question is, how could we, in maybe settings outside of Sydney, be using whole genome sequencing in combination with clinical data to try and better characterise that sort of outcome measure in a cohort that will allow us to measure the predictive value of whole genome sequencing more accurately? And are there any such cohorts that are underway at the moment? Is there a way as a CRE that we could be helping to put together a cohort like that to address that problem?
It's a great question. Greg, very good question. I'm not aware of such cohorts. Cryptic has been really keen to get outcome data in addition to phenotypic and resistome data for subsets of patients. They do have this, but yes, it's a challenge. Similar challenge applies to phenotypic susceptibility testing as well. At the end of the day, from CRE perspective, if we can do even small cohort in comparison, it would be absolutely fantastic. Yeah, but I agree with your comments.
Okay. If there's no more questions, we'll continue on. Thank you very much, Vitali.